Okay. May I call upon the next speaker, Dr. Kabya Khatri? हाँ उसमें absent लिख दीजिए.
नहीं, if they come, they can come.
Okay.
ये ना
3 और बच गए. जल्दी जल्दी खत्म होंगे. जल्दी जल्दी खत्म. 3 और बच गए.
We are in time.
We are in.
जल्दी नहीं है. We are in time.
Good morning to everyone present. The title of our study is Intraoperative Complications in High Volume Cataract Surgery, Quartile-Wise Analysis. To meet a backlog of 3 million cataract size, we have finite clinical.
Please reset the time and you start again. Please reset the time. Okay, you start again from good morning.
Slides change nahi ho rahi.
It's not good getting forward.
No, sir.
Oh. Don't panic, huh?
Yes.
Don't panic. It happens. We are in an electronic age.
Yes, start.
Delhi NCR. मैम प्राइवेट मेडिकल कॉलेज में ना उधर से तो ज़्यादा वैल्यूबल.
Yes, go ahead.
Good morning to everyone present. The title of our study is Intraoperative Complications in High Volume Cataract Surgery, a Quartile-Wise Analysis. To meet a backlog of 3 million cataract eyes, we have finite clinical resources. High surgical volume leads to inevitable mental and physical fatigue and lapse in concentration. This leads to intraoperative complications. Current literature shows significant association between the number of surgeries performed by a surgeon in a single day and the occurrence of intraoperative complications. This, however, is in contrast to the annual incidence of capsule-related complications. This tends to be lower in surgeons with high or very high volume setups when compared to moderate or low ones. We conducted a retrospective cross-sectional study from January to June 2023. We considered manual small incision cataract surgeries which were performed by experienced surgeons. The time of surgery was divided into four quartiles. The first quartile being surgeries that were performed from 7 a.m. to 9 a.m. The second from 9 a.m. to 11 a.m. The third were those that were performed from 11 a.m. to 1 p.m. And the fourth were those that were performed 1 p.m. onwards. Not only did we look at the quartile of occurrence of complication, we also did an in-depth analysis about the type of complication, the visual acuity on post-op day 30, whether or not resurgery was done, and if there were any post-operative complications. A total of 19,206 cases were performed in the 6 months period. In these, we encountered 281 intraoperative complications. The quartile-wise analysis showed that the maximum complications, that is 33.4%, was seen in the third quartile, that is in the 11 a.m. to 1 p.m. time period. The individual type of complication, when we looked at, we found that most of them were in the majority in the third quartile, while some were equal in the third and the fourth quartile, and some were seen maximally at the end of the day, that is in the fourth quartile. 35 patients had to be left aphakic in this time period. Among these, the maximum were in the third quartile. Among the patients who had good visual acuity, that is 618 or better, the maximum were in the second quartile, while those who had poor or average visual acuity, the maximum were in the third quartile. Among these complicated cases, 21 cases required resurgery and 50 cases ended up with post-operative complications. Both of these were encountered maximally in the third quartile. So, surgeon fatigue leads to poor decision making and compromises patient safety. Surgeon fatigue, however, is a modifiable risk factor. Making the surgical team well aware of their roles and responsibilities will lead to a hurdle-free surgical day. Pre-operative planning and scheduling of the more difficult cases in those quartiles, that is quartile 1 and 2, where there are likely to be fewer complications, will be very valuable. Some of the methods to reduce surgeon fatigue include getting good sleep the previous day, taking micro pauses intraoperatively, as well as well-timed breaks, taking care of nutrition and hydration in these breaks, as well as practicing meditation and stretching techniques. Current literature shows the importance of taking well-timed intraoperative breaks. However, there's no emphasis that has been paid to the quartile of operating hours yet. In conclusion, we found that the surgeries that were performed in the third quartile, that is in the 11 a.m. to 1 p.m. time period, encountered the maximum intraoperative complications. Not only this, among these complications which were encountered in the third quartile, the resurgery rate tended to be higher, there were more post-operative complications, and the visual outcome tended to be poorer. These are my references. Thank you.
May I ask one question? Did you analyze the type of surgeons who were assigned to do surgery during 11 a.m. to 1 p.m.? Is it the juniors have been left behind and no, seniors are there during the lunch period? Is it because the reason behind the complications?
Ma'am, the very junior surgeons don't operate for the entire day.
That way,
So
everybody
we-
understand.
yes,
What
ma'am.
I'm asking you, in your case, did you analyze the profile of the surgeons who were left behind at between 11 a.m. to 1 p.m.?
Ma'am, most of the surgeons start in the morning itself at 7 a.m. to operate. Yes, ma'am. It is not so that only the...
Then going by the fatigue criteria, it should have happened in the last quartile,
Yes,
isn't
ma'am.
it?
That is...
So how do you explain why?
Yes, ma'am. That is because most surgeons take a lunch break at 1 p.m. From somewhere between 12:45 to 1 p.m., they take a half an hour lunch break. So the fourth quartile is post that. Post
So,
lunchtime.
so for all the slots, the same surgeon.
Yes, sir. Most surgeons start operating at 7 a.m. in the morning and stop by roughly 3:30 that time period.
Okay. So,
Around 30, sir, 30 to 40. Over different, it is a data collected over 6-month period. So total surgeons would be 30.
High volume surgery, you told.
Sir?
What do you mean by high volume surgery?
Who are performing a very high number of surgeries per
High
day. ma'am.
means what numbers? Because in a particular day you cannot exceed. What was that
The
number?
maximum number, ma'am, would be
No, it's not like that.
on average it would be at least 20 to 30 cases, and the maximum would range up to 50 cases.
Every day,
Not
same
ev-
set.
That is not high volume.
Every day, same set of team is working, doing surgery.
Not every single day, ma'am, but on every surgeon goes
Then,
to the OT twice a week.
How you differentiate which day is more having more complications? Maybe not day. This surgeon's day is having more complication in this period of time, 11 to a.m.
Yes, ma'am. We did not do a surgeon-wise analysis.
So it is also important, na?
Yes, ma'am. Right. Manual small incision cataract surgery, sir. The charitable side. Yes, sir. Yes, sir.
what is the period, what is the slot in your hospital where the fellows and postgraduates are given the cases to do?
We start in the morning, sir, at 7 o'clock.
They start doing operations since morning?
Yes, sir. Yes, sir. The days when there are a higher number of cases, we start at 7 a.m. right itself. Otherwise, 7:30 to 7:45.
Individual surgery by the postgraduates in the morning?
Yes, sir.
Okay. Okay, fine.